Good evening, all the aspirants present here. Today's session is Obstetric Emergency CBS session, and the speaker that we have here today is Dr. Neeraj Kumar, sir. He is an Associate Professor, Anesthesiology and Critical Care at AIMS Patna. Thank you, sir. So you may continue.
Okay, very good evening to all of you and all EDIC preparators. I hope that today's class is related to obstetric emergencies, and what I have planned it that I will try to discuss few important aspects of obstetric emergencies, and then followed by I have kept few of the questions. This is type A and type K questions is already there, but this is all only for your practice, so that you cannot miss any of the stems if it will be available in your exam. Say if you follow a preeclampsia stem, if you get a clinical question on preeclampsia, so they can ask various aspects of preeclampsia, then the patient will land up in eclampsia, followed by they may be developing some features of HELP as well in preeclampsia, HELP following, and then following your eclampsia, and then later on what is the definitive management for eclampsia, and then maybe few of the questions if the patient will, after that the patient underwent some obstetric complications like postpartum hemorrhage, so how will you going to manage that patient? So it will be like that. But here what I have tried to cover all important aspects that has been equally asked in the previous EDIC examination in EDIC part 2 as well. So I will be covering important aspects like physiology of pregnancy, few points, and then postpartum hemorrhage, then some points related to severe preeclampsia as well, then HELP syndrome, amniotic fluid embolism, then your peripartum cardiomyopathy, then following your cardiac failure in pregnancy, how it happens, and what are the basic physiology that is associated with these cardiac failure patients, and then few points about that board regimen, what is this board regimen is all about. There are lots of things that we will discuss later on when I will be starting my discussion. Meanwhile, if you'll have any questions related to any of the point, or if you'll feel any doubt in between that class, you can definitely write in the chat box for any queries. And if the query will be unsolved, then we will try to answer on latter day, or I will pass all those answers to the first academy, and then they will give you all those information, because only to save that time it has been done from my side only. And I think now it's time to start that why these obstetric emergencies are really very important for all of us, or for your EDIC examination point of view. So till now, we all are aware that this pregnancy and postpartum, these postpartum women, they requires ICU admissions, and they constitutes only 0.1%. Means you can say that less than 0.1% of all pregnancies required. That pregnancies are related to ICU admissions, and of all those less than 1% of ICU admissions, their patient will have some obstetric problems. But the problem is that they are mostly admitted for obstetric conditions rather than any other unrelated medical complications. So their primary mode of admission inside that ICU, we'll discuss that what could be the various obstetric causes for ICU admission and non-obstetric causes for ICU admission as well. And most of these patients, many of time, these patients are belonging in a postpartum phase of the period, for which they require ICU admissions, with exceptions of trauma and cardiomyopathy, because it can affect at any parts of the pregnancy status, like your intrapartum, postpartum, or peripartum period. Any it could be anything. And then trauma, definitely trauma-induced coagulopathy is another important aspects that may happen in many of the pregnant patients as well. Now, there has been few studies that they found that the SOFA score is a better predicting system for basically for obstetric patients, for predicting mortality in the obstetric patients. But when you will read about further details about this SOFA, I think for obstetric patient, for emergency emergency triaging, now another term is that is your emergency, or there is a modified SOFA or modified obstetric SOFA. So for which you have to read that part also. They may be asked in your exam that what is modified obstetric SOFA as well. But right now, still we are using, or the various schools of thoughts, they still say about SOFA for predicting mortality, even in the special groups of patient like your obstetric patients, like not only in obstetric, means specifically in obstetric groups of patients. I think still SOFA is one of the important cause for predicting the mortality as well. Okay. And now the important thing is that actual mortality rates are dependent on the disorder that has caused that patient for a ICU admission. Now, the important thing is this is the thing that I was talking, that there was a very good study which was published
Yes.
in the Hong Kong journal, and so I request all participants just please mute. Okay, so it was a very interesting study that was published in your one of the ICU of Pamela Neither Seoul Eastern Hospital, basically from that Hong Kong. It was published in Hong Kong Medicine Journal, and they basically analyzed that clinical characteristics and outcome of the obstetric patients, those who are admitted in the intensive care unit. Although the sample size was very low in this for obstetric patients, those requiring a ICU patient, it was only limited to 50, but you see that total number of ICU patient in this year from 1998 to 2007, around 7,692 ICU admissions were there, out of which 50 patients were exclusively admitted for the ICU, obstetric ICU patient, constituting less than 1% of the total ICU admissions for obstetric patients. And then if you'll see the total number of delivery that institute has been taken care of, out of which 50 patients have underwent ICU admission. So again, it is less than 1% of the approximately 1% of the less than 1% of the ICU requiring all delivery as well, requiring that ICU admissions. Now, among these diagnoses, out of these 50 patients, those who are admitted to the ICU, so 35 patients were admitted because of the obstetric cause, and rest 15 patients were added because of the non-obstetric cause. But if you'll see that in obstetric cause, the few of the findings, like if you leave this PPH, apart from PPH, there are other like pregnancy-induced hypertension, which constitutes eclampsia, severe preeclampsia, and HELP syndrome, then amniotic fluid embolism, then your ruptured ectopic pregnancy, and your peripartum cardiomyopathy. So all these constitute, even the APH also constitute around less than 2% of that percentage of the total patients that were admitted. So these all are your questions for your EDIC examination. Why? Because if you'll see about postpartum hemorrhage, then PIH, amniotic fluid embolism, ruptured ectopic pregnancy, not much, but they can ask definitely about that massive transfusion protocol and policies, and then your peripartum cardiomyopathy as well. And then few of the points related to maternal sepsis or obstetric sepsis as well. But now here, if you'll see that obstetric causes, now interesting to see non-obstetric causes as well. So non-obstetric causes, sepsis, which was the leading cause for admission, and out of which UTI was most common, following your respiratory infections, and then few of the cardiac related admissions as well, in which your rheumatic heart disease was one of the cause. Then CNS related admissions were also there, like viral encephalitis, intracranial hemorrhage, as well as meningitis, and then thrombocytopenia and postoperative monitoring. Although these constitute a bit lesser one, and but obstetric and non-obstetric causes has to be understand in terms of the examination as well, and these are the important topics that we have to read. Okay, now coming to the next part, that now what the physiological adaptations is there for any patients who are pregnant. So there are many physiological changes, and it occurs at the level of fetus as well as placenta. So these are the changes that occurs at the level of fetus, placenta, and at the level of the mother. So modification occurs in almost every organ system has been modified in these groups of patients who are going to get pregnant, right? So many of these patients, the important role is hemodynamic monitoring and ventilation, the two important factors or two important systems that we have to understand. Why? Because we know that progesterone is very important hormone that is responsible for providing these adaptations, and it is one of the most potent smooth muscle relaxant and respiratory stimulant as well. So these are additional two properties of progesterone. It has a smooth muscle relaxant effect, as well as it can increase the respiratory center for providing more respiratory stimulant functions. And then after delivery, what happens that it takes about 6 weeks, means at least 42 weeks, 42 days is minimum for maternal physiology to return to that normal level. So again, this may be asked in your examination, that what is the minimum duration at which the physiological adaptation is going to return to the normal pre-pregnant state. Okay. Now, here again, if you'll further read about that maternal pregnancy adaptation, most dramatic physiological adaptations are cardiovascular, and this is for us because in the exam this cardiovascular system adaptation is going to get, they are usually going to ask these questions with various questions related to cardiovascular physiology as well. Here the first one, the blood volume increases progressively at least up to 50% of in the singleton pregnancy. And then why? Because to compensate the blood loss which is going to happen during the delivery, and the placental vasculature, it is constitute around 30% of the cardiac output. So it constitutes around 600 ml per minute at term. So if it has been asked that what is the amount of blood that has to be present in the placenta at the time of term, so it should be 600 ml per minute. And then around 16% of this maternal blood volume is located in the uterus. So again, this is important aspect, that only 1/6, like 16% of the maternal blood is going to localize in the uterus. And the blood pressure again going to decline by the first trimester, declines during the first trimester to the nadir value, and typically the value ranges from 85 to 110 to 50 to 70 in the second trimester. And these blood pressure again returns to the pre-pregnancy values in the latter part of the third trimester. So you may be going to see some of the shifting in the blood pressure when it is related to your first trimester, second or third trimester.